All righty. Morning, everyone. Just letting people roll in as we just began the webinar. Thank you so much for taking the time to join us for virtual insights on kidney transplantation. My name's Eliza Bensley, and I am joined by my colleague, Jenny Kirschenbaum.
Hello.
And
Welcome, everyone.
we're gonna talk about advancements in kidney transplant today, doing a comprehensive overview. And if you have any questions, please feel free to put them in the Q&A box and we'll take some time to answer them. And I guess, yeah, let's get started. Let's chat about transplantation and go over the history of kidney transplantation. So we'll go to the next slide. So kidney transplantation, of course, has a rich history. So we're just going to cover a couple key highlights. In 1912, Alex Carroll receives his Nobel Prize for pioneering vascular suturing techniques. He invented the first perfusion pump with Charles A. Lindbergh, opening the way to organ transplantation. And if many of you are unaware, we still have our deceased donor kidneys go on a perfusion pump, and we utilize the pump to give us data and help us understand how the kidney's flowing. So obviously a very important pioneering advancement. And in 1954, we had the first successful living donor kidney transplant between identical twins in Brigham. There's a picture up at the top of the screen, which shows Richard, the recipient, who lived for 9 years, while his donor Ronald lived to the age of 79. And the lead surgeon was Joseph E. Murray, shown at the top left. There's a couple of pictures of these twins on the internet, but it's very incredible. And so in 1962, we had the first unrelated living kidney transplant. And then in 1964, Tom Starts published Experience in Renal Transplantation, an important reference for hospitals wanting to establish a transplant program. In the 1980s, cyclosporin revolutionized the field of transplantation. And prior to this, only steroids and the medication azithromycin were available, which generally were not strong enough to prevent organ rejection. So cyclosporin was huge. In 1990, Joseph E. Murray received the Nobel Prize for pioneering work in transplantation, as shown at the picture at the bottom. And then in 1995, there was the introduction of the laparoscopic nephrectomy for living donors, which paved the way for improving the donation experience. That is massive. And I know in the couple slides, we'll show you a photo of the laparoscopic single port nephrectomy that we utilize at our center. And then excitingly, in 2008, we're kind of making a big jump, but the founding of the National Kidney Registry was established. This revolutionized the field of kidney transplant, providing a mechanism for patients with willing but incompatible donors to receive a living donor transplant. And fun fact, the founding transplant for the National Kidney Registry occurred at our center, so we are the founding center. And we're very proud of that, and we are very grateful for the National Kidney Registry. So moving forward, just to cover a couple leaders in transplant surgery. Here are the first two leaders of our transplant program since its inception. Dr. John Witzel performed the first kidney transplant and led the program for many years. The photo of Dr. Witzel is from 1974, and the patient pictured, June Delaney, was the 8th patient to receive a kidney at our center in April 1964. And then Dr. William Stubenboard led the program from 1966 to 2004. He had a very keen interest in organ perfusion as well, as shown of this picture with him with the perfusion pump. So really, really, really neat to be able to have access to these photos from the hospital archives. And then the next slides just a couple of early photos from our transplants in the 1960s, which were obtained again from the hospital archives. So it's just really neat to see where we started and where we've come. And a little more history about our center is in 1963, we performed the first living related kidney transplant in New York. And then in 1965, we performed the first deceased donor kidney transplant in New York. And then in 1996, we performed the first pancreas transplant at our center. And then in 1998, we had our first hand assist laparoscopic donor nephrectomy, which means removal of the kidney. And then just to note, several years later in 2000, Dr. Joe Del Pizzo, who, if you've been a kidney donor at our center, you know that name, he performed his first purely laparoscopic donor nephrectomy, having done his urology residency at the University of Maryland and fellowship here at Cornell. And then in 2004, we performed our first islet transplant in New York, which is an alternative to solid organ pancreas transplantation. And then, as mentioned, our center in 2008, on Valentine's Day, we performed our first kidney pair donation transplant chain with the National Kidney Registry, which we'll cover more about later. And then lastly, in 2009, Dr. Del Pizzo performed the first single port, meaning single incision, donor nephrectomy in New York, further enhancing the experience and recovery of living kidney donors. And so the two photos represent some early milestones of the program, the 200th and the 1000th transplant occurring in 1972 and 1984, respectively. So we've got a really rich history. It's very exciting. And then moving even forward, in 2013, we celebrated our 50th anniversary. And in 2013, we were the first year of the largest living donor kidney transplant program on the East Coast and third in the United States. And then in 2014, we were the second largest living donor kidney program in the US. And then in 2019, we actually had our highest volume of kidney transplants in the history of our program, 279 kidney transplants. And then bringing us back to just last year, we celebrated our 60th anniversary and our 6,000 transplants since our inception, which is really exciting. So 2024 will only bring more transplants to our patients, thankfully. And as you can see, we've been very busy. The allocation change, which we'll talk about later, have kept us very busy. To go over our volumes, as you can see, actually, our number of deceased donor kidney transplants has risen quite dramatically. We've still had extremely great totals overall. We're still a high volume kidney transplant center in New York, and we're a Medicare approved center. And we are amongst the top kidney pair donation programs. And our mission is to maximize opportunities for transplant in order to safely transplant each of our patients and increase access and improve outcomes. So that's our history. And so that's really important when we start to think about the advancements. We really need to always really respect and understand where we started. So just going to go over some basic concepts and terminology. Again, many of you on this call are probably already familiar, but just in case we have some newbies, when we talk about matching the donor to a recipient, there are three separate categories we look at. We look at antigen matching, HLA, and now we're even looking at more specific antigen matching, which is EPLET testing, which we'll talk about later. And then we're looking at blood type compatibility. And then we're also looking at the cross match. So those are the three things we look at. When we say a cross match, and this could be referenced when you're going through a living donor transplant evaluation, or even when you're on call and you're getting the phone call that an organ is available, we might say to you, okay, this looks good. We're interested in this for you, but we're pending a cross match. So That's what we mean when we say cross-match. And it's basically, to summarize, it's when the donor blood is mixed with the recipient to determine if they're compatible. We want to make sure that if the recipient has antibodies against the donor, they're not strong enough to cause an issue. And antibodies are our body's reaction to exposure to a foreign substance, such as a transplant, a blood transfusion. It's our immune system working. And unfortunately, our bodies still think that a transplant is a foreign object. And so our body's initial response is like, hey, this isn't supposed to be here. But there are some people that have higher antibodies than others. People who have had a blood transfusion, pregnancy, a prior transplant may have higher antibodies. And the presence of antibodies may increase the risk of rejection of graft loss if the transplant occurs. So we always are doing our cross match to make sure it's going to be okay. And a negative cross match is actually a good thing. It means there's no reaction. Um, and this chart is just blood type compatibility. So a person with a blood type A can receive from an A and an O. A person with a B can receive from a B and an O, and sometimes an A2, which we can get into later, but that's a very specific case. AB is considered the universal recipient. They can receive from A, B, and O. And O is considered the universal donor because O's can give to anybody, but they can only receive from an O. So that's blood type compatibility. Preemptive transplant is when we refer to someone who receives a kidney transplant prior to starting dialysis. That's always the optimal situation. We would love to have all of our patients come to us preemptively, getting referred early before they need to start dialysis, because dialysis, as we know, can take a toll on the body. And we know that the outcomes are better with a preemptive transplant. Cold ischemia time refers to the amount of time the kidney is on ice between being taken from the donor and placed into the recipient. This is more shared with you if you're receiving a deceased donor organ. Um, if there's 24 hours of cold time, there is a higher risk of delayed graft function, which we can see with deceased donor kidneys. And sometimes when there's DGF or delayed graft function, the patient needs a little dialysis because the kidney's a little sleepy and we need to wake it up. But I'd say DGF is common. And so you will receive kind of the information on the cold time and if there's a potential for DGF when you get your organ offer. This is when the organ offer comes. So matching is really important, but I will say it's not critical to the success of the transplant. For example, a donor with a 0 out of 6 HLA match can still donate. And we are more concerned when it comes to compatibility in direct donation with blood type and a negative cross match. And then just to go back to antigen matching HLA, each person has unique markers on the cells in their body. So again, that's something we look at, but we try to have patients not get hung up on the match because again, it's not imperative for that transplant to happen. So those are just some basic concepts. And as I mentioned about preemptive transplant, only 1/3 of living donor kidney transplants in the US are performed preemptively. In the last 15 years, this rate has failed despite efforts to educate and reach nephrology professionals and the national organization to promote this transplant as a choice for treatment for ESRD. Unfortunately, there is a lack of early referrals, and potentially there might be some delay with the donor eval, and there may be some additional barriers that we can cover. So, something that Jenny and I are doing specifically is really trying to educate and do outreach and provide education to the community as well as the professionals to make sure we're increasing early referrals and allowing our patients the option for preemptive transplant. The next slide just kind of goes through some of the preemptive transplant barriers, and that can be multifaceted. It could be limited patient knowledge of a disease status. Unfortunately, I speak to patients a lot who just found out they had end-stage renal disease. They had no idea. they just found out, and so they're in this point of kind of scrambling to get care. Um, Unfortunately, sometimes people end up in the ER and need dialysis, and they had no idea that they had kidney disease. So really, early education, early intervention, early screening is massively important. Finding if your kidneys are um, in danger of kidney disease is really important. So, again, sometimes late referrals from a nephrologist or to a nephrologist or nephrology time constraints. Limited patient knowledge of available treatment options. This is massive. Some people don't, again, know that transplantation is an option. They may not have a lot of education on end stage renal disease. Um, Difficulty for patients to initiate conversations surrounding donation. This is very common. This is another thing Jenny and I are really working to help patients is talking about how to have the conversation, how to essentially the big ask, big give, and really having these conversations early with family, friends, family members, and your community. And then social determinants of care, of course, are a massive problem too. And inadequate access and inadequate access to follow up. So these are just some barriers that we really need to be aware of. And I think as professionals, it's our job to be aware of the barriers, but understand that there are ways we can help through education, access, and outreach. So, moving forward, again, we mentioned the National Kidney Registry earlier, but the kidney pair donation paired exchange program has revolutionized compatibility and opportunities within living donation. Approximately one third of patients that come to our program will be incompatible with their potential donor. So that means 1 in 3 pairs are not compatible, whether it's blood type, it's cross match. Um, that means there's a large pool of people that need transplants and have willing people. And that is a good thing for us to have is a lot of people who are willing and able to go forward with donation. And our solution is to enter incompatible donors and recipients into a larger pool of other incompatible donors and recipient pairs. Then it opens doors for our patients to be matched with donors whom they are compatible with. And so in our partnership with the NKR, we have been able to transplant over 75% of our incompatible donor and recipient pairs, which is truly incredible. So we are grateful that this paired exchange program is available. They have much better options available for patients. It means that there's not a barrier if you're incompatible with your patient. Um, in addition, other patients who are even compatible with their donors, but are seeking a better genetic match, a better age match, or have time constraints for donation and the recipient isn't ready to be transplanted with, we have voucher donation, advanced donation, which we'll talk about in the next couple slides. But it's really opened up doors. So when Jenny and I are educating patients and they have someone who might be a potential donor, if they think that the patient may not be compatible with them or there's a large age gap, for example, a grandparent and a young child, we know that that's not a barrier. We have options. We have the paired exchange program, which is just absolutely incredible. Um, and so, yes, about the NKR facilitated more than 9,550 living donor transplants to date. That's going to consistently rise. They accounted for 23% of all living donor transplants in the US in 2023, and they have a large donor pool to promote and improve matching. Um, the donor innovations are fantastic as well. This isn't just about the recipients, right? So we want this to be a donor driven process that makes it convenient for the donors. So they can do an online screening tool. They can get tested locally. Say they live in California, but they want to donate to someone here in New York. We can work with the center. We have advanced donation, remote donation. We have the family voucher. We have the microsite program and we have Kidney for Life, which we're going to cover all of these in the next couple slides. And the donors have the donor mentorship program, home blood draws, and the donor shield protections. So Donor Shield is an incredible program allowing patients many protections, such as lost wages, protection should they ever need a transplant in the future. So it is incredible. Um, just to go over the early days of paired exchange, and then I think, yes, I'm going to go over 2 more slides, and then I'm passing the baton to Jenny. Um, in the early days of kidney exchange, simple closed exchanges could facilitate a small number of transplants, usually within a single transplant center. Um, you had an incompatible recipient 1, incompatible with donor 1, and incompatible recipient 2 with an incompatible donor 2, and they just swapped. The unconventional second example is when one pair is blood type incompatible, whereas the second is blood type compatible, but the cross match is incompatible, which means the recipient has an immune system reactivity against the donor. Again, a simple swap of donors enabling 2 transplants. So those were the early days. And then as things have moved forward, we now have the opportunity for long chains, never-ending altruistic donor chains. So you have an altruistic donor or an NDD, non-directed, someone who wants to donate to help anyone, a stranger. They start the chain. And so their kidney goes to one recipient, and then that recipient's potential donor goes to another patient, and so on and so on and so on. And this was actually the example of the first chain that we did in 2008. And all these patients were able to get transplanted. And the last pair became a bridge donor, which started another transplant chain several months later. So pretty cool. Pretty cool. And yeah, I think actually, no, I'm going to end here. Benefits of living kidney donation. So why would someone donate their kidney other than to help their loved one or a family member or a friend? But why would someone donate their kidney to a stranger? Well, kidney donors tend to have higher quality of life scores after donation than the general population. This may be related to an increase in donor self-esteem and sense of well-being. They also are showing improved psychosocial health after donation. And also, the screening process that the donors do go through has sometimes helped uncover certain diagnoses that may benefit from early intervention. We obviously hope that doesn't happen, but it can. And so the early detection of medical issues, and we have the Donor Shield program. But I love this quote from one of our altruistic donors. Doing good feels good. I wish everyone could feel the joy and pride of experience through this journey. I never thought I would be able to help save someone's life. This only had a minimal impact on me as the donor, but was life-changing for the recipient. So we're very lucky we have altruistic donors. And yeah, now I'm going to pass this over to Jenny, who will be able to talk about the management.
So our donors, one of the things that we boast about is that our donors really do have very good recovery and they have really good protection. So Eliza touched on before that, the history of living donation, that the first laparoscopic procedure was done pretty invasively. There were really large incisions. The surgeons had to hand assist, which, could lead to more complications, a more invasive procedure. Our program with Dr. Del Pizzo was the pioneer in really developing the most minimally invasive approach. We were one of the first programs in New York to use this approach, and we remain sometimes a center that people will come from all over the country just to have our surgeons perform this approach because it really does have the best outcome. So the operation time is one of the key elements. It's generally 2 to 4 hours, sometimes quicker, which is great because that's minimal time that the donor's under anesthesia. There's less surgical pain reported than an open approach. Sometimes patients, stay up to 2 days, but I would say the majority of our donors do go home after one night in the hospital, so they're able to get home quicker to heal. And most of our donors are able to resume their activities of daily living and light work after about 2 to 3 weeks, which is great. We also offer to all of our donors, Liza mentioned Donor Shield. That is a protection through the National Kidney Registry. Not every center offers that to every donor. We do, which offers them up to $6,000 of lost wage reimbursement. So for our donors, if they do have to take off that time of work and they're not compensated, they do get that reimbursed, as well as dependent care and caregiver coverage if they're not able to take care of their children or a family member that they're typically responsible for. Our donors are not able to drive for about up to 2 weeks postoperatively. All of our donors are given access to private rooms on the concierge floor at our hospital, and we follow them very closely for up to 2 years post donation to ensure that their kidney function recuperates and that they're supported in their recovery. Advanced donation, remote donation are two terminologies within the National Kidney Registry. Eliza mentioned before that one of the facets of the National Kidney Registry is that we often have patients choose to go into the kidney registry, even when they are compatible with their family member or loved one. And that's because the donor is given that additional convenience. So the donor basically picks their date that they're able to donate. The recipient is then activated to receive their transplant after the donor donates. The logistics are much more simplified. So, when we went over in that slide in 2008, when we started kidney paired exchange, we had very, very long chains of transplants, and the donors and the recipients were typically donating either the same day or shortly after. And the issue was that often there were cancellations or bumps in the road, whether there was a hurricane in one place where the kidney was going or coming from, and then we lost those matches, and often the transplants would be delayed. So the wait time in paired exchange in current day is very quick. Patients are waiting sometimes as quick as days to up to 6 months, the longest that a recipient ever waits for a transplant in the kidney paired exchange, which is great. It also is a convenience for family members. It's less stressful when you have, a parent and child or a husband and wife who are going under surgery at the same time. Separating those surgeries allows the family members to focus on both of their individual recuperation. You can get a better matched kidney in the paired exchange program because you're opening that donor pool. The donor, again, has access to Donor Shield, which we talked about, have significant benefits for donors. And remote donation is a really excellent facet of the National Kidney Registry because it's able for us to tap into all of the participating centers from all over the country. So even if a patient has a donor in North Carolina or California, we're able to do testing. Sometimes even the surgery can happen in those other centers, and it's really convenient for the patient. I will say at our center, most of our out-of-state donors do choose to continue to come to our center here because of our outcomes and our excellent surgery approaches, and also because we have that reimbursement for travel and lodging, donors often still opt to come to us. So the voucher program, I usually explain the voucher as like a coupon, if you think about it, but basically once a donor donates, they're usually donating on behalf of a recipient, and that recipient then has a voucher or a coupon that they can basically activate to receive a transplant. There are different types of vouchers. So there are patients who are looking to receive a transplant imminently. They are ready for transplant and they are cleared. And so those are called standard vouchers. That donor is donating right now, and that recipient is expected to receive that transplant within the next year. There's also called family voucher donation. So patients can actually donate on behalf of somebody that may need a transplant in the future. So we have patients who are very young, who need transplants, who we know that they unfortunately will need multiple transplants in their life. And so we sometimes have donors donating in advance for a future transplant. What's really nice about the family voucher donation is they're actually able to list 5 potential people on that voucher, so that if that initial person they were intended for it to go to for some reason never utilizes, they have 4 other people that they've then protected in their place. So this gives our donors a lot of peace of mind. This is a benefit that's offered to our altruistic donors. Another answer to the question, why would somebody ever do this altruistically? And beyond them just being incredible people that want to help others, there are a lot of protections and allowances that give them that peace of mind. Well, what if my child, what if my sibling, what if my family member develops kidney disease? They get to protect somebody else, their loved one, outside of that person they were donating for, which is really incredible. So this is one of our pairs, Sophia Jackson. I mentioned that people out of state tend to come to Cornell, even though they live so far away. Sophia heard about Adrian, who is a New York City police officer and a mother of two young children that was in need of a kidney, and came all the way to us from Utah to come donate for Adrian. They had an incredible meeting. Adrian is one of our beloved patients. We just saw her at the kidney walk with her two young children. She's doing incredible. Sophia is doing amazing. They have a really beautiful relationship. And technically, Sophia was actually an altruistic donor who did not know Adrian directly, but was touched by her story, which we will get to the slide on microsites. And I know Eliza, very passionate. If you've been on, our webinars before, she talks a lot about the microsite program, but it's a great opportunity to share your story. So, if you are a potential recipient, so that someone like Sophia may come forward. The Kidney for Life program is a program that we participate with through the National Kidney Registry. And it's basically an opportunity for patients to get a more sophisticated and higher level of matching for their transplant. So it's utilizing a new technology in DNA sequencing, looking at eplets, which we talked about HLA. Those are the genetic markers, but eplets are smaller components of that marker that allows for improved matching. And the terminology we use, which is, if this sounds confusing to you, it's confusing for us, even the medical world, but we want a low eplet mismatch that is technically like a higher level of matching. So, because there is a large donor pool with pair exchange, they're giving patients access to potentially these lower mismatched kidneys, which could have longevity in the transplant graft and ultimately be using less immunosuppressive medication, which is usually the goal when we are talking about matching. So the opportunity is to reduce the risk of those antibodies, that immune response that Eliza was talking about earlier on. We don't want those antibodies to form post-transplant. That lowers the risk of rejection, less risk of that kidney to fail, a lower dose, hopefully, of immunosuppressive medications that need to be utilized, which for patients can have a lower risk of side effects. We are only one of 2 centers in New York and 8 centers in the Northeast that offer all of our patients access to this Kidney for Life expert system. So, we did talk about earlier that matching is not everything. And this is a great example that although the Kidney for Life program is an excellent opportunity for our patients, we will help guide you in the transplant process to know if that is a program that would benefit for you. So all of our living donor pairs get eplet testing very early on in their process via a cheek swab. So it's, a non-invasive way of checking. We always advise patients if it makes sense for them. The Kidney for Life program cannot offer a better match than a 50% genetic match. So when we have a sibling or a parent-child that has a significant level of matching, we usually don't advise them to go into the Kidney for Life program. Additionally, timing and knowledge is very key. So we have patients that come forward and they have a clear donor and they're preemptive and they're approaching dialysis. We're not going to recommend that patient to, spend time waiting for a better match and paired exchange. So our transplant team is here to guide in the expertise for older recipients. Having an opportunity to a living donor transplant is getting them that best option. And again, they don't necessarily need or could benefit in the same way as a very young recipient from these low eplet mismatched kidneys. So we guide our patients to know what is beneficial. I'm going to let Eliza cut into the microsite program because I know she's very, very passionate about this.
Thanks, Jen. Yeah. So I really hope all of you on this call have heard about the microsite program. If you haven't, it is a great opportunity to get your story out there. It's a free personalized website, and you're able to, again, make it unique to you, add photos, write your story. And you'll have some assistance because you got assigned a microsite coach, someone who has had experience helping their loved ones find a living donor. The microsite program is, again, pretty easy to use. And so I really think all recipients, if they don't have a living donor, should try, because at this point, I think there is no harm in trying to spread the word, trying to see if you could find someone who might have never considered living donation. Maybe they're unaware of the donor protections or the benefits that Jenny had just mentioned. So it's really a free tool. Um, Patients get business cards with their unique URL that the site creates. There's a QR code. You can throw them at a local coffee shop, a YMCA, your place of worship. It's just a low lift way to try and spread the word. Um, the next slide, I believe I have a sample site which shows just an example. You have the person's photo, you have their name bold at the top. There's built-ins to Facebook, Twitter, and your email if you want to share. Sometimes patients are like, I don't have anyone I think who would be able to help me and donate to me. And I say, well, if there's people that can't do it, but maybe they can help share your site. Maybe they can be your donor champion. Maybe they can be someone who takes the burden off of you as the person living with end stage renal disease. Patients then can see if they're qualified to donate by clicking the button at the top. And then they can read more about why the patient needs a transplant. So it personalizes the ask. And then I like that there's the donor support and protections built into the website, such as Donor Shield, just bringing awareness if people have never thought about living donation. And there's more opportunity for personalization. So, um, this is just a great example of a site. There's many sites that are out there now. It is on the patient to share the site. If it doesn't get shared, it really just lays dormant. So we always encourage patients to again identify a donor champion, someone who may not be able to donate to you, but is impassioned to help you and would be interested in sharing the site because you just never know. We've seen patients go crazy with their microsites and create massive social media campaigns, and you have a lot of people coming forward. And the site actually is able to kind of weed out the people that are serious because they have to do something called pre-workup labs, which shows some commitment. So again, the microsite program is relatively new. We started it in 2021. And we were recovering from COVID and whatnot, and things have really grown. So again, this is a free tool. Any recipient can make one, and we are able to help you if you're interested. So, um, and then the next slide, I believe, just talking a little bit about our overall um, clinical practice, maximizing opportunity, our mission statement, right? Maximizing opportunities for transplant, our research, our outcomes, our real goal to minimize exposure to immunosuppression. We're a steroid sparing center. Our PAs and our pharmacy are always working, with their nephrologists to try and minimize immunosuppression with Kidney for Life. Of course, now um, there's potential for patients to really minimize the medication they're on because there's immense side effects. So, and then for maximizing opportunities, we are utilizing marginal organs and we have kidney paired donation. Um, and then as far as our translational research, non-invasive monitoring, we have the opportunity to do non-invasive testing to make sure, versus a kidney biopsy, which is invasive. And yeah, that's kind of just a overall summary. Wanted to include that. And I did want to cover our outcomes because this is kind of the proof in the pudding on how our transplant center performs. So we have the patient survival and we have graft survival. When we say graft survival, we're talking about the kidney. And if you can look here, we have the adults versus the peds, but I'll just really focus in on adults. If you look at our survival rates, 1 month, 1 year, and 3 years, um, they really are in line, if not better than the national outcomes. Um, I know our 3 year outcomes, 89.74, we did have some patients that we unfortunately lost during COVID, and so those outcomes kind of are trickling in. But overall, it's been really, really a great year. And so, as far as the graft survival, again, you can see that we're neck and neck with the national rates, and so we're really proud of our outcomes. Further advancements. So yeah, many of you maybe have heard of tolerance, and that's a revolutionary breakthrough for kidney recipients to live without immunosuppression drugs. There's upcoming research studies and trials, and that's really exciting. I'm very excited to see where that heads, and to maybe one day have a patient that never has to take immunosuppression again is a pretty amazing opportunity. And then, of course, just addressing the national organ shortage, which is still continues to be a massive problem. We have an immense amount of patients on the waiting list. As you can see here, almost 90, 900, like you can see the amount of patients waiting versus the amount of transplants that are done. So we're utilizing high KDPI donors, small pediatric organs and organs from donors with HIV and HCV, which are all, again, really contingent on the recipient. We have to make sure we're placing the right kidney with the right recipient. That's really our practice model. But making sure that our patients are getting off dialysis faster, giving them the opportunity for a better quality of life. And yeah, I think there are very, very exciting things ahead. And again, if you've not been to our website, please go weillcornelltransplant.org. Visit our kidney center, our living donor kidney center, which provides information about donor criteria, evaluation, surgery, risks, frequently asked questions. Watch our presentation with the National Kidney Foundation called The Big Ask Big Give, which helps kind of guide starting that conversation. And if you are not following us on social media, please follow us. And if you would like to read our quarterly newsletter, we send it out every quarter. You can reach out to me and I would be happy to get you on our list. And I think that's it. I think we're questions now. And I really appreciate all of you guys listening. I know it's a lot of information, and if we don't have any questions, we will give everyone 15 minutes back of their day. But thank you, Jenny, so much for your
Thank you everyone for being here.
immense knowledge base.
And you guys can always reach out to us. If you do have any questions, I can just put our information in that chat so that you guys have it.
Yeah. And so our webinar series does take a pause in December, and then we will restart everything back in January. And so next month we kind of just take a month to regroup. The holidays are coming up, so we know everyone's really busy, but thank you for being here, and we will see you in January.
Happy holidays.
Bye.